So I will touch on now, all the morning sessions we have talked about pediatric cataract, how it should be treated, managed. Yes, in our private clinics it is very easy. When the patient comes, we do the best. But where do these patients come from? That is a big challenge. So now we know that in the prevalence of cataract in children is between 1 to 15 per 10,000 children. So it is the most commonly performed intraocular surgery in the pediatric population worldwide. It has far-reaching effects on the child and the family. In a study which we did, Orbis supported 6 hospitals. A questionnaire was administered to 1,070 parents, and we just wanted to know what is the social construction of pediatric cataract, that is how parents make sense of their child's condition. And it was interesting to note that the factor analysis showed that the parents, they have 3 major barriers. There was access to services, economic difficulties, and beliefs that the child is too young for surgery. Now we all have, the clinics are with best infrastructure, state-of-the-art equipment, but where are the children with cataracts? They are all hidden in the community. We have to bring them to the clinics. So we found with the camps with SSA data that the children of 7 to 8 years of age are still hiding in the community and not operated for pediatric cataracts. Why have they not been operated when we talk in all symposiums that pediatric cataract should be operated at the age of 3 months, 4 months, intraocular lenses should be placed as early as possible. But what happens to these children? Why have they not been touched? So we did screening camps for 2 years in the community, mainly in Uttar Pradesh and Rajasthan and Haryana. The primary screening camps are around 710. We screened 22,398 children. Out of that, 427 only were pediatric cataracts. So imagine the cost expensive, how much of cost is required. We have to screen such a huge amount to get this amount of surgery for this amount of children with pediatric cataract. And then surgeries done were only 237 because most of the children were either dropouts or unfit patients. So what happens to these children? So it is important that we have to strategize how to get these children and get them early into the clinics. We have to diagnose them early. So now the concept of the 3-tier system where we screen children at the vision centers where the field worker gets them, referring them to a secondary satellite center and then transporting them to a tertiary hospital is working better because then the dropout rates are much lesser. So we find over the years when we started that was just 227 pediatric cataracts we operated in spite of having the best infrastructure, the best equipment, but children were not coming. But over the years we find that the numbers have increased because of changing strategies on detection of childhood cataracts. But the sex distribution is still the same. The males and females, it is still the males coming more to the clinics, even over the year, or around 8 to 8 years. Now the interesting thing is that even the age distribution over a period of time has not changed. Means even now children less than 2 years are still not coming to the vision centers. So we find still we are getting children above the age of 6 years. So we need to really think to put IOL in a 3 months baby or a 4 months baby, where are the children? So we need to start awareness programs. We need to go out into the community and educate parents or workers, health workers, that these children have to be treated early. So how to catch them early? The main problems I think in the community level is the GA facilities for these very small children. Less than 5 years, less than 4 years, the ophthalmologist may be willing to do, but there is a scare of doing them under general anesthesia because most of them do not have well-trained anesthetists or they do not have well-equipped centers for general anesthesia. So that is why maybe the ophthalmologist may be telling the parents, please bring the child a little bit later, or they may be referring to a higher center, but because of economic problems, the children are not reaching the higher center. So there are various methods where maybe we train more technicians, we do them at least smaller, slightly bigger children, we do them with block and with ketamine. Or maybe in some centers, like I've seen in Pune, that they are doing bilateral surgery basically to reduce the cost of anesthesia. The problem also comes putting the IOL power. Now in centers, in tertiary centers, we have well-equipped keratometry, we have well-equipped IOL power calculation, A-scan machines. But how do we calculate them in these centers, in the periphery, in the secondary centers? So it is very difficult because putting a wrong IOL in a child is even worse. You may make them again blind. So we need to have these equipments also along with other facilities. Because we have to have a portable keratometry, which is again expensive, an A-scan machine, and these may have to be done again under anesthesia. We have methodologies where just doing axial length, we can calculate the IOL power. We need not buy the high-tech keratometry, handheld keratometry. But these are the techniques where we can still put an IOL power, can calculate the IOL power. Now, in spite of doing the best techniques at our tertiary center, we still find that what we target refraction and what we get actual refraction, there is a variability, there is still a prediction error, because till now we have not found the accurate IOL power formula for children. So there is so much variability in children less than 2 years and in myopes. So what IOL would be appropriate? The foldable IOLs. All literature search says that we need to put Acrosoft IOLs in children, but there is a cost factor. So PMMA IOLs, the Apasami and the Fred Hollows, they are providing IOLs at low cost. But can they be put in children? Yes, they can be put in children, but with a proper surgical technique. We need to do a proper surgical technique in managing all these pediatric cataracts. We can't say we have no anesthetist, so we won't do this technique. We will just remove the lens and leave it. But again, the child will become blind because of posterior capsular pacification. So we need to do the best technique, or we need to refer to a higher center, or we need to get funds to do these techniques in a proper manner. So the technique what we follow is, in children with less than 6 years, we need to do posterior capsular access with anterior vitrectomy. It is not difficult. We have training facilities provided by different projects. So we could train ophthalmologists, cataract ophthalmologists to do them, but these need to be done in a proper manner. Now in cases with nystagmus or secondary centers, without a YAG cap facilities, we still need to do PCC with AV even with older children. It's not that 8 years, because America is doing an essays that after 6 years no need to do PCC with AV. It does not mean in India we should not do, because most of them present very late to us. Then we need a proper surgical equipments like a trained pediatric cataract surgeon. We need an automated machine for doing the lens aspiration. Yes, we can do it with a normal technique of doing an SICS with a tunnel, and we can aspirate them with Simcoe. But even with this, we need a vitrectomy machine for doing a PCC with anterior vitrectomy. Now the management also differs, because we find that these cataracts over a period of time, they also have different morphological features. So I'm going to the steps of the pediatric cataract surgery, and each step is crucial because we need to do each of these steps to get a proper clear visual access after cataract surgery. Now the training methodology could be that we could learn these techniques in adult patients and then slowly shift them to pediatric patients. We are doing rexes in all our adult phacos. We can just learn to do them in children with the rexes forceps. So we can switch gradually in doing pediatric cataracts in children. We do not need a phaco handpiece for removing the cataracts. In the community, if we have a bimanual with an automated machine, we could remove the pediatric cataract with the bimanual only, or even if we do not have a bimanual, we could remove them with a simple Simcoe. But the most crucial step is doing a primary posterior capsular access. Otherwise, if you leave it at this, we do find that it again opacifies. I will just do a few steps of the pediatric cataract, the posterior capsular rhexis. It is important that we properly do this technique with heat. Now the problem is we need high viscoelastics in doing this technique. That also is a cost factor. So we need to find out methodologies of how to do them even with a low cost viscoelastic devices. So it is important for us to do this, because if we do not do this in the community, children may not follow up, we may not be able to do YAG for them, and we do find that they again opacify. So it is important that we have to do the posterior capsular rhexis, and along with it we need to do an anterior vitrectomy, because if we do not do an anterior vitrectomy, the posterior capsule, the anterior hyaloid face, it will again opacify. So this machine, anterior vitrectomy machine, should be available in all pediatric cataract centers. So now what we find in children in the community, we find that they come with long-standing cataracts. Mostly their posterior capsules are opacified. We cannot do a simple PCC. We need to do them with a vitrectomy cutter alone. Rather than doing it manually, we may need to do it with a cutter. So this highlights more that we need to have the cutter in all our pediatric setups. So whenever funding is asked, we have to ask for this instrumentation. Now putting an IOL, maybe all of us, maybe our patients cannot afford a foldable IOL, because this is the best technique of putting a foldable IOL in the bag, and we find that putting them is much easier than putting up PMMA lenses. But maybe we cannot afford it in all patients. So, but non-foldable IOLs, PMMA lenses also are good enough, but we need to ensure that the PMMA lenses are put in the bag. What happens is that we do not put them in the bag of fear of extension, and then what we find that there is pupillary capture or glaucoma, and again we are dealing with another portion of childhood blindness, that is secondary glaucoma after putting an IOL. So it is really crucial that we put the lens in the... So even if the children present early at less than 2 years, we find that we get a very good outcome. But if they present later, we get only in 75% of children we get vision less than 660. So we need to bring them early. We also need to follow up these children regularly, because this is important for amblyopia treatment. If there is any glaucoma, we need to follow them up regularly. Now we have a follow-up of after 2 months. Our follow-up rate is 24.2% who did not follow up. This is because we have funding and projects to bring the children back. But it is crucial that we ensure that the follow-up of children is done regularly and very rigorously. I think the most, Dr. G.V. Rao will now be talking of the many community challenges we have, and how along with Vision 2020, he will tell us how they have tried to improve these challenges in management of pediatric cataract and also in managing childhood blindness. Thank you.